So, let us talk about the general features of the diaphragm. We call them as the diaphragm, as this is the big and quite large diaphragm that the body has. So, this particular diaphragm is a muscular partition as well as tendinous partition. So, it has a muscle and it has tendons, and these muscles and the tendons are anchored in the different walls that we have in our body, like the bony attachments. It has sternal attachments, it has costal attachment, it has vertebral attachments. So, these particular muscles are taking origin from 3 different sources or 3 different attachment points. One is on the sternum anteriorly, on the costae, and as well as it is attached on the vertebra. So, it have got like different sleeves of these particular muscles attached to it, and from these attachments it is going towards the central part, which is tendinous. So, this particular diaphragm, if you look into it, it is looking like this flat structure. It has some central part which is bedded with this particular superiorly with this fibrous pericardium above. So, the central part of the diaphragm is tendinous, which the central part is there. More we go to the periphery, we will see this particular muscle fibers are present on it. And on the back side, posterior side, we have this vertebra on the back side present in our body. To the vertebra, lumbar vertebra L1, 2, 3, 3 vertebrae are there on the back side. On this particular vertebra, transverse process and the body of it, we have the muscular sleeves attached of this muscular part of this diaphragm, which is the vertebral attachment bodies, which is anchored to the posterior side. So, these particular posterior attachments of these particular muscle fibers of the diaphragm, which is anchored to the back side, we call them as crux of the diaphragm, C-R-U-X, crux. Crux means leg. So, this particular diaphragm having got muscular part, having got central tendinous part. So, muscles are of 3 origins: sternal part, costal part and the vertebral part. Vertebral part has a special name, we call them as crux of the diaphragm. We have 2 such crux are there, one is on the right side, one is on the left side, right crux and left side. Right one is larger than the left one. Right side having attached to this particular right side of the transverse process vertebral body L1, L2, L3, and this L2 and L3 lumbar vertebra transverse process where this left crux is attached to it. So, this is about this muscle attachment this particular organ or this particular viscera has. Apart from that, this particular diaphragm is not a flat structure. It has, if you are seeing this, it has bulges and a flatness in between. So, we have 2 bulges of the diaphragm, we call them as right and left dome of the diaphragm, and the central flatness, which is the central tendinous portion, which is holding this particular pericardium along with the heart on the top of it. So, we have this crux of the diaphragm which is bulging on right side and left side. Right bulge is greater than that of left side, because the right side under to it we have a large organ placed, we have the liver, and because of the liver it is pushed up little bit higher than that of left side. Left side we have the spleen under to it and stomach as well, which is little bit in a lesser volume compared to the right side. So, that is why these particular bulges of the diaphragm are there. These bulges are predominantly fleshy, that means we have muscle fibers on these bulges. So, this particular element, how does this look like about the diaphragm which is holding it, and the functions of the diaphragm is that it is a kind of like a partition organ between this particular abdominal cavity and the thoracic cavity, separating it, and this particular element is a organ for respiration. Whenever you are breathing in, breathing out, this particular diaphragm moves up and down whenever you are doing, especially this particular inspiration. Whenever you are doing this breathing in movement, this particular diaphragm plays a central role whenever you are taking this breathing in quiet respiration. If you are just like exerting, then we need extra muscles belong to this particular diaphragm. Now, this particular diaphragm having placed in this particular partitioning component between this thorax and abdomen, we need to have some kind of openings through which this particular organs which are passing through this thorax or coming from the abdomen, which needs to go up, moves through it. So, through the diaphragm we have some openings, we call them as large openings and the small openings of the diaphragm which is present on it, which is allowing this particular vascular or neurovascular structure to move up and down. So, this particular opening helps us to move this particular large vessels, that is like aorta, intravena cava, which is going up and down, and as well as food tube, which is esophagus, going down from the esophagus to the stomach. This can be travelling through, and bypassing through and reaching this. So, for that the diaphragm have got pierced by some kind of openings which have. We call this particular opening as a major opening of the diaphragm. We have 3 such openings, we call them as major opening of diaphragm. So, this major opening of the diaphragm are 3 of them. So, 3 of this opening are present for passing of 3 major structures which is passing through. Say for example, inferior vena cava, esophagus and aorta, which is going to be thoracic aorta to abdominal aorta. So, these 3 structures are there which is piercing this particular diaphragm, and they are more a major piercing structure which is coming in here. So, this particular opening makes this particular diaphragm or passes through diaphragm through some holes, we call them as major opening. They are not at plane present at the same level. As I am saying, diaphragm not a flat structure, it looks like parachute. So, it is kind of like a bulged up and tacked down. So, as a result of this, these openings are also not at the same level. So, this inferior vena cava opening lies at level which is higher, T8 level. Then we have this T10 and T12, that is how these particular openings are there. So, apart from this particular major structure like esophageal opening, inferior vena cava opening, we call them as vena cava opening, esophageal opening, aortic opening, which is passing through these major structures. Along with that, we have some additional structure also passes through it. We will go and talk about it. But these particular elements are going to be the major things, which is called them as IVC opening, esophageal opening and aortic opening, and lying at this particular level vertebral, that you have to need to remember through it. Now, this particular diaphragm apart from this major opening might have or have some kind of smaller opening, we call them as minor openings, which is passing through the other neurovascular structure, nerves, splanchnic nerve, etc., etc. So, if you can remember this minor opening, it is fine, or else just let go, just remember this particular major opening, what structure passes through, at what level these particular openings are there. That much is essential for us to remember at this undergrad level. Later on, whenever you are doing something bigger and greater related to the surgical field, then we can remember the intricate detail about the minor openings and all these things. Now, this particular diaphragm is a musculotendinous organ, that means it needs some kind of muscle supply, that means we need some motor supply to this particular diaphragm to move. We have this particular diaphragm supplied with different kinds of nerves that we have to need to remember about. The number 1 nerve we have to remember this supplying here is phrenic nerve. That phrenic nerve we have dissected out in the thorax, goes down through the neck region and comes down to this mediastinum and supplies this particular diaphragm. The funny part about this particular phrenic thing is that this particular phrenic thing is pierces the diaphragm, goes under to it and supplies the diaphragm under from inside. So, after piercing it, then supplies this particular diaphragm with a recurrent branch that goes under, then it supplies back. That means, it has a recurrent course whenever it is supplying this particular muscles of this diaphragm. Apart from this, this particular diaphragm is supplied by these intercostal nerves. So, on the sides or margins of it, we have this intercostal nerves, which is typical atypical intercostal nerves we discussed about. So, intercostal nerves which are also giving this motor supply to this particular diaphragm. Apart from this, which are motor supply, this particular diaphragm has got sensory supply. So, the sensory supply of the diaphragm also comes from different sources. Number 1 is that same phrenic nerve. So, phrenic nerve supplies this particular thing as this sensory and as well as motor, and as well as this intercostal nerve which is having this particular sensory divisions, as well as it supplies this particular sensory parts as well, especially on the margins of it, it is supplying the sensory parts of the diaphragm along with this particular intercostal nerves. So, intercostal nerve and the phrenic nerve, these are the two dual structure or dual nerve that is supplying the sensory and the motor supply to this particular organ whenever it is doing some muscular action or picking up some touch pain temperature sensations which is coming on it. Now, other than this is a living structure, we need some blood supply to this particular organ to feed this. So, we have this particular artery supplied with this particular branch of this abdominal aorta which is present on the left side supplying to this particular organ. We call them as the phrenic artery. So, we have 2 sets of artery, superior and inferior phrenic artery, easy to remember from this particular phrenic thing. So, phrenic nerve and phrenic artery, superior and inferior, they are principally supplying this particular organ above and down, and then intercostal arteries which is present in the intercostal space, atypical one, they also supplies this particular thing along with this particular blood supply. So, intercostal and as well as the phrenic superior and inferior, they are supplying this particular organ from different areas. So, central part and the peripheral part is supplied by the sensory supply, motor supply. Similar to this particular nerve vessels, we have these lymphatics, we call them as phrenic group of lymphatics, superior phrenic group of lymphatics, inferior phrenic group of lymphatics, which are draining this particular organ to this phrenic group, which is on the sides of the aorta or side of the inferior vena cava or great vessels, and then takes it to the higher group of levels, lymphatic channels like cisterna chyli to this particular thoracic duct, and eventually drains this particular organ to these particular points. So, these are the things that you need to know, understand about this particular diaphragm whenever it is related to this particular basic understanding of this. Now, coming to this movement of the actions of these things. So, movement or actions, that is important. So far we can remember about this particular diaphragm is a principal inspiratory organ. So, it is an organ of principal inspiration, that means whenever you are breathing in, this particular organ is working. So, breathing in actions happens over here, principal inspiratory organ, which is this one. With this organ, whenever this is getting the impulse, this particular organ gets this muscular contractions. So, what happens with this inspiration, this particular organ contracts, especially the muscular part, and this particular muscular part contracts and pulls this particular dome down. So, as a result of that, this particular domes of the diaphragm, which is upish in this expiration part, when this inspiration begins, it drops down. So, we call them as flattening of the domes. So, domes become flat because of the pulling from these muscles from the sides. Side দিকে টানলে যেরকম হয়ে যায় নিচে নেমে যাচ্ছে. So, this is because of the side traction that is happening in here on the posterior traction as well. So, as a result of that, there is a descent of domes of the diaphragm. As you have the descent of the dome of the diaphragm drops down. So, they have a vertical downward movement of the diaphragm with the inspiration. So, the diaphragm moves down. As a result of that, we have this particular thoracic cavity above and the abdominal cavity down. So, as a result of that, the volume of the thoracic cavity becomes large. As a result of that, there is a negative interthoracic pressure. So, if you have the volume increased on this thoracic region, we have some kind of space created. As a result of that, there is a negative space, traction is there. As a result of that, air gets in. So, we have this particular negative interthoracic pressure sucks the air in as this particular diaphragm drops down. Similar things happen here. If you have this particular diaphragm dropping down, we have this particular increase in intraabdominal pressure. So, because of this particular thing is dropping down, the space inside the abdominal cavity is reduced. As a result of that, this particular space is reduced, we have a cramping of these organs which is present in here. So, we have a rise on abdominal pressure and the release of the interthoracic pressure, as a resulting in air can be getting in. That is how this particular mechanism of breathing in, breathing out happens over here. So, this particular contraction helps us to drop down these domes of the diaphragm. It is going down, we call them as flattening of the dome. So, it is going down right side and left side likewise, and intra-abdominal pressure going in. So, this is one thing that is happening in here about this particular movement of the diaphragm and how this principal breathing movement takes place. Now, along with this breathing, what is happening out here, we have this particular inferior vena cava which is taking this particular blood from this lower part of the body to this particular upper part. Now, as this particular thing, we have this negative suction created, we have a movement of this blood flow also changes in this particular direction as well. So, what happens with this particular descent of the diaphragm is that, so we have this inferior vena cava IVC which is going to drain to this particular heart chamber, we call them as the atrium right side. So, this particular inferior vena cava is taking the blood and going towards these directions, and as it is crossing the diaphragm with this particular descent in here and release of this particular negative intrathoracic pressure, we have this particular blood which is coming through this inferior vena cava, whatever is going here is increased. So, we have an increase in venous flow through IVC within this particular during this inspiration. That is what also this happening because of this particular descent of the diaphragm. So, whenever you are going down, this particular diaphragm is going down, we have this particular release of this particular or less of this intrathoracic pressure. As you have less intrathoracic pressure, air gets in, as it is sucked in through the outside, this inferior vena cava blood which was going in as well will be sucked in as well. So, there will be a pulling of this inferior vena cava blood. As a result of that, we have the venous flow or venous return. We call them as venous return, which is happening more in case of this inspiration. So, during inspiration there are two phenomena that is taking place. One is the air get in, which is because of the negative interthoracic pressure from the outside, air getting in from this particular blood which is getting in through the inferior vena cava and going to the thorax to drain to this particular aorta also will be sucked in because of this negativity. So, there was a release of pressure. So, the air which was passing through, the resistance out here is released, and as a result of that there is an increased venous flow which is going on. Moreover, we have this intraabdominal pressure which is released. So, abdominal viscera also pushing this particular blood which is going through the abdominal aorta to this inferior vena cava, abdominal viscera to this part, and will be moved up. So, there will be blood which is going, for example, if the blood is going through 15 ml during each cycle, then there will be 5 ml plus, for example, will be increased. So, we have an increase of the venous flow to the heart. So, blood will be receiving more blood whenever we are breathing in. When the air gets in, blood is also getting in from the lower parts of the body through this part. So, this venous flow return also important phenomenon that is taking here. So, this phenomenon, this action or this venous return or fate of the venous return or managing of this venous return will be covered in detail in physiology or physiological understanding, where they ask a lot of questions about it. Why this particular venous return is there, what happens to the venous pressure, etc., and how these things are happening. They will be asking about this particular elements in the physiology, and you will be learning this. So, we prepare this particular venous return part of the blood flow during inspiration, what happens with the movement of the diaphragm. This is another part which you have to really understand out here. Apart from that, there are some positions of the diaphragm which works very good. So, diaphragm is having this particular movement up and down when it is going up and down, works in particular position at very best. So, as we are sitting or little bit leaning or leaning backwards, in this particular position the diaphragm works best. So, the diaphragm when it is in a relaxed stage, sitting forward or stepping back like this, works best in this particular position very well. And the movement of the diaphragm is restricted when this particular the patient is in a lying down position. So, if the patient is lying in position, because of the abdominal viscera, they will be pushing these things up, pushing this particular thing up, and as a result in this diaphragm will be pushed up. As a result of that, because of the lung is also there, the heart is also there, this particular movement of the diaphragm will be hampered. So, as a result of that, you will see that when the patient is having some kind of breathing difficulty, they will be sitting in position, they will be sitting up, getting up, they cannot lie down, they will be sitting, climbing up or raising this back, and then they are just like taking the breath, and they find easy in taking the breath in a sitting or semi-sitting positions, because of they can move this particular diaphragm really up and down well whenever they have some kind of respiratory difficulty. We call them a dyspnea, D-Y-S-P-N-U-A. So, this particular dyspnea is a labored breathing which is happening to a patient who are suffering from lung disease like COPD, asthma, heart failure, etc., etc. These are the cardiopulmonary conditions where you see this particular problem of the breathing difficulty. So, that particular breathing difficulty patients you will see prone to inclined forward or sitting in positions and take the breath. They cannot sleep in lying down position. They will be sitting all night while they are breathing in, because of the while they are like sleeping at that particular supine positions, the movement of the diaphragm will be restricted because of the liver, and this particular abdominal organ will be pushing high and the movement of the diaphragm will be restricted. So, this particular diaphragm works well, moves very well in a sitting or semi-sitting positions, that means 45-degree recline positions. So, if the person is reclined in positions like this, so whenever you have this particular patients in your clinic or in your clinical life, you will be addressing some kind of patients having breathing difficulty, make this particular patient recline in 45-degree angle position. So we call them as recline 45-degree. So 90-degree will be like this, so will be 45-degree reclining positions. That's the best position where the diaphragm can works. That's the scientific reason. Putting this particular person in this particular region where the diaphragm and the respiratory muscles works at best. So that's the position that we have to keep this particular patient in to relieve this particular breathing difficulty. Along with that, you do the treatment as well. Now, other than this, if you elevate the leg as well, it helps this particular person as well. Whenever you are just like putting some kind of cushions under to this particular leg, like a knee and this particular part as well helps this, so that the venous return will be just like getting easily and this particular blood flow is going up. So this redundance of the blood which are not be pulled into the lower part. So this particular positioning helps us to understand why we are placing this particular position in this particular position when this particular patient having some kind of respiratory difficulties. Now, having said that, how you will be tested in examination? They will be giving, they are not going to ask you about straight questions about tell me about the attachments of the diaphragm, how this particular thing are there, or else etc. etc. Those questions may not be asked in examination. They will be giving clinical questions like explain why this person who have the breathing difficulty placed in recumbent or kind of 45-degree angular positions. So then we have to see about this particular justifications of putting this particular patient in the particular positions where the diaphragm works well. In a respiratory problem, you have to understand what this respiratory problem is through your physiological knowledge, biochemistry knowledge or anatomical knowledge. What this respiratory problem means to us and why this particular respiratory problem relieves little bit with these particular positions where this particular thing can be patient as ease or itself patient will be sitting in this particular position while the patient is sitting in a respiratory problem patient inclines to sit in a position or inclines to a recumbent or 45-degree angular positions. So explain why with your anatomical knowledge or anatomy physiological knowledge. What happens to the venous flow when this particular patient is breathing in and what happens to the venous flow when the patient is breathing out. So if this particular venous flow is increased when you are breathing in, what happens to the venous flow whenever you are breathing out? What happens to the venous flow? So it will be reduced, it will be opposite. So the venous flow will be propagated, will be accelerated when you are breathing in towards the heart, and the venous flow towards the heart will be reduced whenever you are breathing out. The same opposite mechanism will be there. So there will be intrathoracic pressure which is reduced, now it will be more. So you have a more intrathoracic pressure, then air needs to be pumped out or thrown out, which is elastic recoil of the lung is going to happen. And if you have thoracic pressure increased out here, the venous flow will be just like obstructed, it will be pushed down. So likewise it will be there and more diaphragm will be pushed down. So if the diaphragm is pushed down, so this particular space will be accommodated accordingly. So these particular problems you need to understand whenever you are studying to it. So this just like only learning or understanding about this particular anatomy only about the diaphragm is not only or not sufficient only to answer these particular questions related to the diaphragm, because diaphragm is a very much vibrant organ and it changes the positions each in respiratory cycles as we are coming across in breathing conditions, in resting conditions, in supine conditions, everywhere it is changing and it is a very very important vital organ. That is why understanding this particular diaphragm or the movements of the diaphragm during this particular respiration is kind of important. I am just like giving a visual about these things, we already have seen this, but just like the basic understanding of the diaphragm just we have learned about, and the major opening and the minor opening, those things you have to memorize rot actually. Unfortunately, the openings of the diaphragm as I am saying. So this musculocutaneous organ, how it is placed, you can see that these are the bulges here, muscle fibers are on the periphery, central part which is tendinous. If you seeing from this above, from the below, this particular thing is abdominal part. These things which is hanging over here, leg-like structure with the vertebra, we call them as crux. This is known as legs. So diaphragm is like this and standing on the legs, it is making kind of like a hunch like this. It has a higher hunch on the right side, left side less. The central part is tendinous into which on the superiorly we have this pipe recording this there. Three parts are there: sternal, costal, lumbar, etc., and central tendinous, supplied by the phrenic nerve. It has a major opening like this. We have this vena cava opening, esophageal opening, aortic opening present at different sites, which is passing this particular inferior vena cava, esophagus, and this aorta, abdominal aorta, going to be after the thoracic aorta like this. Along with this, we have this particular thoracic duct, and azygous vein passes along with this particular aortic opening. So, along with this aorta, this thoracic duct and azygous vein also passes through this particular aortic opening. Like this particular thing, esophagus also through the esophagus passes through the vagus nerve. So, right vagus, left vagus passes through this particular esophagus, going down through it. Inferior vena cava, we largely see inferior vena cava passing along with this inferior vena cava with that only. So, having said that, this diaphragm movements of the diaphragm that we have mentioned, we have the three kind of movement, which is respiratory or respiratory thoracic cage experiences, which is known as this bucket handle movement, pump handle movement, and this particular vertical piston movement. The vertical piston movement, as I am referring here, is because of the contractions or relaxation of the diaphragm. This principally affects the domes of the diaphragm. The central tendinous portion does not move that much whenever we are just like a breathing in and breathing out. So, this particular, beside this particular pump handle, bucket handle movement, the vertical movement of the diaphragm is based on descents of the diaphragm, and to be specific, descents on the domes of the diaphragm, that means the bulges, which are muscular part. Now, this particular vertical diameter increase, as it is contracting, it moves down. That means, whenever the vertebra is diaphragm is contracting, it is going down. Is it going down? That means towards the abdominal cavity. That means the intrathoracic pressure is negative, air gets in, blood gets in. So, venous flow is increased, air flow is increased. Opposite happens with the opposite action as we are expiring or breathing this particular thing. Expiratory muscles extra to it. If you need the forceful thing, then we need extra muscles, thoracic muscles, neck muscles, abdominal muscles, based on how we are doing it. So, this particular thing is explains how this particular contraction of the diaphragm happens, and this particular muscle is relaxed, it pulls down, intra-abdominal pressure is increased, and this one is released, and as a result of this particular thing, reverse things also happening over there. Inspiration and expiration, how this particular thing is there. This is what we are talking about, the dyspnea. Whenever you have the breathing difficulties, sitting up in position, because of this diaphragm is sitting position, is lowest ventilatory capacity is required to it. So, that is why we have this particular position, and we can exercise this neck muscle in this particular position. Fix this particular arms like this, we can make this particular intercostal muscles and as well as chest wall muscle to move this or expand the chest wall muscles, and this particular thing which is works well. And diaphragm is highest in position, as I am saying, supine in position, lying down in position, diaphragm will be pushed up. As a result of that, movement of the diaphragm is difficult. So is in kinds of lowest sitting positions. So, this is what we have to keep in mind regard to this particular diaphragm, muscles movements and this particular thing, and along with this we have to remember about this phrenic nerve, which is supplying, along with this forget about the intercostal nerves, intercostal arteries, which supplies this particular diaphragm whenever it is relieving or receiving this particular blood flow, sensory supply and the motor supply to the diaphragm, or these things. Now, coming to this irritations of the diaphragm and the clinical part of it. So, whenever you have these irritations of the diaphragm, that means when this particular diaphragm is irritated from the under surface to it. So, little bit about the phrenic nerve, how this particular phrenic nerve is coming. So, which concludes the clinical problem based on the diaphragm. So, as I am saying, the phrenic nerve is supplying this diaphragm, which is right side dome supplied by the right phrenic nerve, left side dome supplied by the left phrenic nerve. Now, this phrenic nerve has a root value of 33, 34, C5. That means it is coming from the neck region. It comes all the way from the neck to supply the diaphragm. So, for this we have to know and understand the phrenic nerve origin of it, which is coming in the neck region. So, diaphragm is also present or developed in the neck region. So, we have this particular diaphragm developed in the neck, and because of the development of the heart, it was pushed down to this particular normal position right now what it is. So, to start with, diaphragm developed in this particular neck region, and as a result it is developed in the neck region. This phrenic nerve, which is taking the nerve source from it, is at this particular root value C3, C4, C5. Now as this particular diaphragm with this developing heart pushing down, the diaphragm descends down and settles down to the abdominothoracic partition region. So it settles down. So when this particular diaphragm descends, this particular phrenic nerve also drops down along with it. So this right side phrenic nerve, left side phrenic nerve is sourced or developed from this neck region, supplies all the way from neck to here to reach to supply the diaphragm, because diaphragm is dropping down from the neck region. So as it is going down, diaphragm is also pulling down this particular nerve source at its screaming. So when this particular diaphragm is getting and settling over here, then finally it receives the blood flow supply from this abdominal aorta like inferior phrenic artery, superior phrenic artery, but the nerve source is carries from this neck region. Now this particular neck region which is supplying, or this particular dome or dermatome of this region, especially this C4, is at the nape of the neck or the shoulder or tip of the neck, tip of the shoulder I should say. So if you see this particular person, we have this particular C4 dermatome is around this particular C4 region. So if you see the dermatome pattern, remember the dermatome pattern we talked about in the class, we have this particular dermatome pattern. So C4 dermatome, that means C4 spinal nerve, which is cervical region spinal nerve, supplies the skin region over this tip of this region. Now this particular diaphragmatic nerve is a nerve, we call them as mixed nerve. So it has a sensory supply, it has a motor supply, right. Now it supplies the diaphragm out here, supplying from this particular lower part like this. Now if by any chance this phrenic nerve is irritated by this particular diaphragm or something else, this particular nerve carries this sensation along with, reaches to the brain higher center. Once this particular brain perceives this particular irritations or some kind of sensory problem over there, brain cannot differentiate between whether this is coming from this particular diaphragm related origin or somewhere from this origin. So this particular C4 spinal nerve supplies this particular neck, shoulder region or tips of the shoulder region, as well as supplies this particular diaphragm. So if you have the irritations of this particular phrenic nerve, the pain may be referred to this shoulder tip region. So we call this phenomenon as referred pain phenomenon. So this particular referred pain phenomenon, we do not have exact clue how these particular things are working, but we see that if you have the irritation of phrenic nerve because of any reason, it could be like anything which is creating or making trouble to this particular diaphragm, or making trouble with the pleura, making trouble with the pericardium, where the sensory supply of the phrenic nerve is coming, we have an irritations of the tip of the shoulders, right side and the left side likewise. If the right phrenic nerve is irritated, we may have a pain or discomfort over the right shoulder. If you have left one will be irritated likewise. So a referred pain phenomenon, or explain why kind of question is there. So this phrenic nerve, diaphragm or under surface of the diaphragm, or any kind of like a pleura or any kind of pericardium, if it is irritated, we have a pain felt over shoulder tips. Explain why. So this particular explanation comes with is, this is a kind of phenomenon, we call them as a referred pain sensation, where we have a irritations which is carried through the phrenic nerve, cannot differentiate where from the pain is actually coming, and it refers to the dermatome where this particular phrenic nerve is supplying. So this phrenic nerve, as I am saying C4, that C4 dermatome lies on the neck region. If you go through this particular C4 dermatome with these pictures, or the dermatome picture as we have referred, that makes this particular thing clear again, and that helps us to identify this problem based on it. So once again, if you go to this particular dermatome pattern about this particular nerve supply on this region, that clears the doubt why this particular referred pain is referred to the tip of the shoulder if we have the phrenic nerve irritation by any chance. So this particular region is paining if you have a dermatome pattern which is followed through the phrenic nerve irritation. So as a result of that, tip of the shoulder, the phrenic nerve is formed by the nerve which is known as C3, C4 and C5. Out of this, C4 is the predominant, like phrenic nerve is having a mixed spinal nerve, have got three different sources coming from the C3 source, coming from the C5 source and coming from the C4 source. Out of that, C4 is a predominant fiber. So, if you have a phrenic nerve problem irritation, that burns this particular tip of the shoulder because of the irritations. So, we call them as a referred pain sensation. Somewhere the pathology or disease is, and it is referring to somewhere. It is a kind of misleading understanding of this misleading thing, unless until you know the anatomy, you cannot explain it why. Sometimes we have this particular phrenic nerve problem, maybe you have a gallbladder problem. So, gallbladder is under to the liver, and that particular gallbladder, if it is inflamed, or even the liver, if it is inflamed, irritates the under surface of the diaphragm. So, under surface of the diaphragm, that phrenic nerve is irritated, and then that particular thing is referred to this thing. So, the patient is, you will be seeing that coming over here, আমার ডাক্তার বাবু শোল্ডারে খুব ব্যথা, কাঁধে খুব ব্যথা, হাত তুলতে পারছি না, কেমন একটা অস্বস্তি হচ্ছে, সব সময় ভেতরে লাগছে, and you will saying না আপনার তো গলব্লাডারে অসুবিধা হচ্ছে, বলে ডাক্তারটা কিছু জানে না, কিছু পড়াশোনা করেনি, টুকুটুকে পাস করেছে, শান্তিনিকেতন মেডিকেল কলেজ থেকে, তো আমি জানি সব টুকুটুকে পাস করে। তখন কি বলবে? বলবে না 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 না, আমি কঙ্কালীতলায় গিয়ে যোগ্য করে মায়ের দীক্ষা পেয়েছি, মা বলেছে এখানে হয়েছে, বলে ও মা বলেছে তাহলে হবে, তাহলে ঠিক বলেছে ডাক্তারবাবু। So you have to explain it with this particular anatomical language, why this particular undersurface of the diaphragm with the pain on it. It could be liver problem, could be gallbladder problem, could be any problem. So if you have a irritation of the phrenic nerve, no matter what the organ is irritating, it could be like the pleura, because pleura is supplied by the phrenic nerve, that particular pleura which is related to that, we call them as mediastinal pleura. It could be like the pericardium. The pericardium also innervated, the fibrous one, also innervated by this particular same thing, which is phrenic nerve, may have irritations of the tip of the shoulder. So cardiac problem, lung problem, liver problem, gallbladder problem could have a relations to tip of the shoulder pain, referred pain phenomenon, right? So all the organs is referred to with this like this. Yes, if it is linked up to with the phrenic nerve, it can be, because the phrenic nerve has a root value of C3, C4, C5, out of the C4 fibers are there. So phrenic nerve is a mixed nerve, it is taking 3 different sources, তিনজন মিলে তিনটে নার্ভ মিলে phrenic nerve বানিয়েছে, তিনটে স্পাইনাল নার্ভ, সার্ভাইকাল স্পাইনাল নার্ভ, এই নার্ভটা বানিয়েছে, এও বানিয়েছে, এও বানিয়েছে, এবার contributions from the C4 is the predominant, 90% fiber is coming from C4. So C4, C3, C5, they are coming together making a common nerve, which is this. That's not the all, that means কি ও খালি ওটাই বানিয়েছে? No, not only that, the C4 nerves also doing some sensory supply to this part, কিছু ফাইবার বানিয়েছে, কিছু ফাইবার contributed to form this particular, some of the fibers is contributed form to this phrenic nerve, rest of the fibers is supplying the skin, supplying some of the muscles, yes, that too. Clear? So this particular problem, referred pain, in physiology also you will be learning about this, phantom limb, referred pain, etc., etc. They will be explaining these things again and again. So explain why these kind of questions will be coming again and again. Okay, ভিসার একটা বার করে নেব পরে, ঠিক আছে, ব্রেকটা হোক, তারপরে একটা ভিসার বার করে নেবো, অ্যাবডোমেনে অনেকগুলো আমাদের আছে, সো উইল ক্রিয়েট প্রিপেয়ার ভিসার, রাইট? তোমরা আসবে এখন একটা দিন ক্লাসের ডিসেকশনে, তোমরা বার করে নেবে একটা, ঠিক আছে, একটা ডায়াফ্রাম আমরা বার করে নেবো। So we will see the crush, how this it looks like, how the dome of the diaphragm, how the central part is there. So we will talk about that.